Okay, so before anything else, I want to first go over the U of M traditional territories acknowledgement. But I think making it more accurate is something that I aspire to do. So um, this version of the territories acknowledgement is kind of more reflective on the actual events that have took place in the past and that are still taking place today. So the University of Manitoba campuses are located on the original and stolen lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and on the homeland of the Métis Nation. We respect the treaties that were made on these territories. We acknowledge the harms of the past and that are still being made today, and we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration to dismantle white supremacy and to actively participate in decolonization. Okay, but now I'll kind of go over who I am. So first of all, I'm Mackenzie. I graduated last summer with a Bachelor of Science in Biological Sciences. And throughout my undergrad, I spent a lot of time doing research with Dr. Jeffrey Marcus. Some of my time was spent doing mitochondrial genome editing and analysis, but by the end of my tenure in that lab, I was doing a lot of analysis on high elevation adaptation through a group of organisms called caddisflies. They're otherwise known as mayflies, which you may be familiar with from fly fishing. Currently, though, I'm a master's student in the Department of Community Health Sciences through the Rady Faculty of Health Sciences, of course, which has been a complete 180 for me, going from like very benchwork oriented stuff to more qualitative data analysis, focused science, but I've been loving every single minute of it, and would recommend this program to everyone. My thesis for my degree will be looking at the relationship between chronic kidney disease and muscle loss, otherwise known as sarcopenia, and any adverse health outcomes like extended hospitalizations, falls, mortality, things like that. So far in my master's journey, I've only worked on my proposal, but I'm looking forward to working on this more to come in May. So after my master's, I'm also hoping to pursue the Master's of Physician Assistant Studies program here at the U of M, and work clinically in primary care with a focus on chronic disease management, and maybe a PhD, but we'll see how that goes. And actually last year I was also an MHRA trainee, so it feels nice to be feels nice to be full circle back here again today. Yeah. Okay, so just to go over where I come from, my ancestors hailed from the lands of Ukraine, Iceland, and the United Kingdom, and immigrated to Canada at the turn of the 20th century, seeking economic opportunities. My father's family settled on Treaty 1 lands, and my mother's family on Treaty 2 lands, farmers and fishers. My mother is the daughter of a farmer and a nurse, and my father is the son of 2 school teachers. And roughly 5 generations later, I was born and raised here in what we know now as Winnipeg. I also thought it'd be interesting just to kind of put up some of my historical names, as they have changed quite a bit, or some of them have when immigrating to Canada. So on my dad's side, my name is Alexiak, but it's changed from Oleksiak and Oleksiak. And on my dad's mom's side, it's Johnson is the name, but it originally was Johannesson. And then, of course, my mother's side, we can see that these are all very white names that have not changed since immigrating here. So I just think that history is interesting. And finally, I just want to go over some things that are important to me, being who and what are my relations. So first of all, I am a daughter, granddaughter, sister, niece, cousin, and grand sœur. I say grand sœur because I was an au pair in France in 2017, which was an amazing experience. And this family now considers me their big sister and daughter. So that's an important part of who I am. For those of you who are looking for something to do after your undergrad and not quite yet doing grad school, I highly recommend au pairing. It's an awesome experience. If you want information, you can reach out to me about that. But otherwise, though, I am deeply passionate about chronic diseases and their management, of course. So chronic diseases have been affecting my family members for as long as I can remember. My dad in particular suffers from one, ankylosing spondylitis and Crohn's disease. Ankylosing spondylitis is a type of arthritis that causes a lot of body inflammation and can sometimes fuse the vertebrae of the spine together. And then Crohn's disease is just, again, general inflammation of the digestive tract. But also heart disease and stroke run in my family as well. I also want to touch on some of the organizations that I'm affiliated with, as they have all greatly shaped who I am. So of course, I'm a student at the University of Manitoba and have been since 2016. I've also been involved in the competitive swimming community since 2004, and have since been coaching swimming for going on 8 years. And I'm also a researcher primarily through the Chronic Disease Innovation Center, which you can see here, under the supervision of Dr. Navdeep Tangri, but I'm also still finishing up some projects with Dr. Jeff Marcus. I also love volunteering at Cancer Care and Swimmingly. I'm a patient guide at Cancer Care and a special needs instructor with Swimmingly. Another plug, Swimmingly is always looking for volunteers, so if you'd like to give back to your community, highly recommend Swimmingly. Feel free to get in touch with me about that as well. And now finally, I am also a teacher, which I think is really cool. Thanks to the MHRE program, and thanks to you all for participating as well. Finally, in my spare time, I love baking, reading, doing puzzles, and generally spending time with my family and friends. And of course, if you couldn't already tell, I'm passionate about chronic diseases, primary care, and all things improving, all things relating to community health. But enough about me. Let's take a few minutes to kind of hear about you. So I will stop the screen share and pull up a Menti page quickly. Okay. What have I done here? Okay. So there's that. Can everyone see my Menti screen? Awesome. I see someone's tapping yes. Thank you. Thank you. And I will also quickly do this so everyone can see that. Fabulous, fabulous. It's also in the chat. Awesome. I think there's about, so it says there's about 39 of us in here. I'll wait till we're at about 30 people in here and then we'll get started. Oh yeah, also if you're in here, could you please tap the little heart button so I can see that you're in here? Almost there. Okay, you know, we'll just get moving now. I think we're 25. I'm guessing there's 5 people that just haven't hit. Oh, 26, perfect. Okay, let's just get moving. Okay, so I just kind of want to get a feeler out there. What topics in health research interest you? Is it more benchmark kind of stuff? Is it more qualitative data analysis kind of stuff? Just generally, what kind of topics are you interested in? Love to hear it. Pharmaceuticals, cool. Stem cell theory, cool. Epidemiology, cardiology. If you like epidemiology, I have the program just for you. Wow, this is awesome. Cardiovascular and heart, cool. Disease, data analysis, yeah, cool. Cancer, yeah. Immunology. Microbial research, awesome. Rehabilitation research, it's really cool. Psychotherapy, really cool one, yeah. Oh, this is really awesome. Neurobiology, yeah. Looks like immunology and cardiology are the front runners though. That's really awesome. If you're interested in cardiology, the same B is where you gotta be. It's really cool over there. Cancer reoccurrence. Awesome, awesome. Okay, cool. Awesome. I think we'll move on from this slide. Thank you everyone for sharing. Let's go on to what are your career goals now? We're thinking clinical practice, health research, a mix of both. Not at all sure yet. Cool, okay. The one person that's unsure, that's totally fine. Not healthcare related. Oh, cool. I'm glad you're here joining us though anyways. Clinical practice, mix of both. Yep. Awesome, awesome. Good mix of clinical practice and mix of both. I fall into the mix of both categories, so I'm with you there. Yeah, nice. But yeah, awesome. For those of you who are unsure, you still have lots of time to figure it out. Don't worry, you got time. Okay, cool. We're gonna go into the next question then. Okay, why did you sign up for MHRE? I'd love to hear this. Exposure and experience, different fields and topics. Yeah, I gain more knowledge about it. Yeah. Variety. Yeah. These are awesome answers. See other options I have for careers and to make sure pharmacy is what I want to do. I like this. This is a really good answer. This is kind of why I'm actually doing my master's program, the CHS master's program that I'm in. I've always kind of known I want to be in clinical practice, but I also really love doing research. So yeah, I think this is awesome. Also, for those of you, the person who was wanting to go into pharmacy, there is also an option for you to do research as a pharmacist, of course, too. So there's an avenue for you to do both there, if that's what's good for you. Awesome. Really great answers, everyone. I'm also dental hygiene and health science undergrad. Cool, awesome. So if I want to work in healthcare or not, fair enough. It's best to do that while you're an undergrad and still have time to figure out your life before you commit to everything. Fair enough. I like this answer. Learn more about health science. Yeah, great. Awesome. Okay, thank you for sharing, everyone. I'm gonna move on to the next slide now. And just quickly, have you heard of my department before, Community Health Sciences? Before I started talking about it, I know I was just sharing with Camilla that I had, okay, good. I hadn't heard about the CHS department until fall of 2021, which is when I applied to the program. Hadn't heard about it. I hadn't heard about it until then. And I'm thinking that CHS needs to be advertising their program more, because I know I've heard of immunology and pathophysiology and MedMicro, and I've heard about all those other programs, but I didn't hear at all about CHS. So it's good information. Highly, highly, highly recommend the program, though. It's amazing. Okay, awesome. Okay, so we're gonna head back to PowerPoint now. And I will get us back onto that. Okay, thank you everyone for sharing. That was really awesome. Okay, so anyways, so as you know, I have mentioned that I am deeply passionate about chronic diseases, but I'm also deeply passionate about primary healthcare, and but why? So I have a story about my my healthcare journey, and that's kind of what got me into being passionate about primary healthcare. So it all kind of started in 2019, when I found a lump in my neck. And I kind of just fell down this rabbit hole of looking and speaking with primary care providers. Like a lot of people, I think, well, like a lot of people, I would assume, I immediately first thought was cancer, because, whenever you think about a lump, all I think about is cancer. And so I made an appointment with my GP. But my GP unfortunately brushed me off, wouldn't take any of my questions, and warned me that they might put me on medication if I kept being nervous about this lump. So that kind of again led me down this rabbit hole of trying to find other healthcare providers. So then between November 2019 and February 2020, I bounced around between the different practitioners until I was finally referred to an ENT. And so that was great, because I finally felt like my concerns were being heard. The primary care practitioner who referred me to this ENT also thought that maybe I would need a biopsy or a CT scan just to kind of figure out what was going on. But yeah, this was the first time I felt like in this lump situation, I felt like I was being taken seriously. But of course, we all know that something happened in March 2020. So then, of course, this all became complicated. And I eventually ended up getting a CT scan. I see your question, I'll be right there. I ended up getting a CT scan. Given the complications in the healthcare system, I didn't get a biopsy. Thankfully, it came back non-malignant, but I eventually figured out about a year ago that the lump was caused by scalp psoriasis and not by anything nefarious. Let me get the question now. An ENT, great question. An ENT is an ear, nose, and throat specialist. Sorry, everyone. ENT it's a short for ear, nose, throat specialist, but in like the specialty term is an otolaryngologist. But yeah, it deals with ear, nose, and throat doctor issues. So this is kind of my healthcare story. But I think it's important to note that if my family had doctor in November 2019 had taken my concern seriously and answered my questions about the lump and, you know, respected me and all those good things, I don't think I would have gone through this whole experience. I think my experience would have stopped right here. And none of this extra stress that I had or excess radiation would have been put onto my body. And that made me realize how important good primary care is. And I want you to kind of carry the story with you as I go through this presentation, because this is really important also for chronic disease management. Okay, so why does this matter? So although I've come out okay from this journey, you know, this experience still matters. It's made me realize how important primary care is for well-beings of individuals and communities and populations. So of course, I've since switched family doctors, which has totally shaped the way how I view primary care, and it has allowed better communication and empathy from my family doctor, and it's made me feel like a person. So primary care is so important. But other benefits of that apply to more than just myself when it comes to good primary care is better education to allow for correct access of secondary and tertiary services. So for example, I really didn't need that CT scan. I'm totally fine. And the only reason why I got it was because of COVID and this whole rabbit hole that I fell down. But I accessed that service incorrectly, technically. So like that better primary care will provide patients with better education and resources to correctly inform their decision about accessing these services. So for example, secondary services are like specialist services like radiology, cardiology, those kinds of things. And then tertiary services are like services like dialysis and burn care and other complex treatments. But I mean, the same principles still apply. Primary care allows you to best access those services. And primary care is also the most accessible level of care. In theory, you can walk into any walk-in clinic and see a physician, physician assistant, nurse practitioner, or whatever. And they will provide you with the kind of care that you need and help guide you to maybe other care that you might need as well. Also, this kind of care is super important for disadvantaged and marginalized communities, which is why the lack of consistent primary care in rural and northern communities in Manitoba is so concerning. And finally, kind of tying this into chronic diseases, it's the best practice for our aging population. We are getting older, and that will cause huge problems down the road unless we can address this primary care issue sooner than later. And so of course, there's many benefits to emphasizing primary care, but two I want to point out here that are particularly relevant for this presentation and for just the fact that Canada is aging is that it emphasizes primary preventative care, and it is key for chronic disease management. Yeah, so then we're going to start getting into some other terms. So I also want to highlight that there is a difference between primary care and primary health care. These terms are often used interchangeably. And I've even been saying primary care instead of primary health care just because it's one last word. But there is a difference. Primary care is considers the services that are provided by physicians, most frequently family doctors. So like the family doctor type services, so like blood work, diagnostic imaging, things like that are covered under primary care. And then on the other hand, we have primary health care, which kind of takes a step back and looks at the systems in place that support and guide our primary care practices, and usually considers the patients interacting with the system. But it's also important to note that patient care can fall into both camps depending on who you're asking and what the definition of both these terms is. Generally, though, in Canada, we think that patient care falls into the primary health care, but of course, it depends on who you ask. And I also want to note that 9 times out of 10, the research that is done on primary care versus primary healthcare is done on primary healthcare. Yeah. And these terms are also related. Primary care guides primary healthcare, and primary healthcare guides primary care. They're so interrelated, and they both inform each other's decision-making processes. And yeah, they're both interrelated, and which is why I'm kind of bouncing back and forth between terms, but know that they're used interchangeably, but they do technically mean different things. And I also want to go over the history of primary healthcare before we get into its impacts. I think context is super important in understanding why our healthcare system is shaped the way it is. But first, we'll start with the Alma Ata Declaration by the WHO in the 70s. And this declaration introduced the concept of health for all, and highlighted the importance of primary healthcare as the locus for equitable global health. And then in 1984, the federal government signed the Canada Health Act, thanks to the work of Tom Douglas, the Premier of Saskatchewan at the time. And this act ensured that all services deemed medically necessary would be paid for by the government, and not out of patients' pockets. However, the Canada Health Act is in no means a perfect document, and it is the main reason why most primary care physicians operate on a fee-for-service model. We'll touch more on that later. Following that, the WHO released an update to the Alma Ata Declaration entitled Now More Than Ever. And they noted that some improvements were made, but not everywhere and not equally, let alone equitably. And most changes that were occurring for the primary healthcare system were taking too long to be implemented. And so this one of the factors of why primary healthcare is the way it is in Canada, like I mentioned, is because doctors operate on the fee-for-service model. And that results in doctors kind of taking their practice where they'll get the most patients. So, for example, a northern community might have a population of about 200 people that a single doctor could serve very well. But if that doctor can't get enough appointments to pay their bills, lease fees, pay their staff, they won't be able to stay in that practice no matter how much of a golden heart they have, because unfortunately the physician relies on the patients for billable services that they can get paid through. So this makes primary healthcare, especially northern communities, very, very complicated. So I mean, Canada generally has a pretty good primary healthcare system for some, but definitely not all. And this fails to meet the standards of the Alma Ata Declaration and the update Now More Than Ever. So kind of again, touching on the physicians as fee for service, this makes things really tricky again, because physicians will practice where they will be able to make a living, and it's not based on the needs of the community, which obviously results in inequity of care. Also, as I'm sure everyone are all acutely aware of, there is, of course, the physician shortage that we are coming upon, and the practice of the family physician practice will be the most hardest hit. Throughout Canada, according to the Canadian Institute of Health Information, approximately 1 in 6 family doctors are near retirement age, and many others are reducing clinic hours or being forced to shut their practices without passing along their patient load to a new physician. And this will further contribute to inequity in care. And to make matters more complex, the role of the family doctor is super complex as it is. They do so much more than just take doctor's appointments. Some are responsible for coordinating billing and other administrative fees, and some also have hospital duties if they work in rural regions. So this makes really good primary healthcare really hard to find. And this will only get worse as more family doctors retire. And to even make this even worse, less medical graduates are wanting to pursue family medicine. According to the Canadian Residency Matching Services, or CARMS, of all the unmatched residency seats available in 2022, being 115, 99 of them were for family medicine. And there were also 83 graduates who did not match all, meaning that these 83 graduates had the option to pursue family medicine. There was more than enough seats for them to take, and they still didn't take that family medicine seat. So instead of practicing family medicine, they are now essentially like it's a horrible way of putting it, but like they essentially don't have a job because they can't practice medicine without having residency experience. So it's just kind of this horrible situation that we're in. And this number of seats that have been growing, the number of empty seats for family medicine has only been increasing. There was 86 seats left unfilled in 2021 and 49 seats left unfilled in 2020. So it's just getting worse. And so, of course, the structure of family doctors puts constraints on primary care access, but there's also other issues too. And this list is by no means extensive, but I think it highlights the main issues that we're seeing here in Manitoba. So I'm sure, as we've all again seen in the news, that there's huge wait time problems, which is causing an issue in continuity of care. So many Manitobans cannot see the same care provider due to one, lack of family doctors, and turn to walk-in clinics and emergency departments or urgent care centers. And that affects the relationship between the provider and the patient. And if they do have a family doctor, many Manitobans also have to wait extremely long periods of time to see their doctor or access services that their doctor may provide. I have two examples about this. So first of all, I have a close friend who is a trans man, and he was sharing with me that before the pandemic, the wait time to get hormone therapy was about 3 months. And the wait time to get top surgery was about 6 months to a year-ish. And now now after the pandemic, this wait time has jumped from 3 months to 15 months to access hormone therapy, and jumped from 6 months to 2 years to access top surgery. And to get bottom surgery, you have to go to Montreal. So the wait times for services that are absolutely considered primary care are not being offered to patients at the rate that they are needed. Further, if any of you have seen your primary care provider and they've requested you to get like a CT scan, MRI, yada, 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 the wait times for that are also outrageous. Another friend of mine who's currently going through medical training, she told me that she had a patient who was complaining of headaches. Her doctor sent her for an MRI, but the MRI wait time was, I think it was 8 months. And in the meantime, the patient had a stroke. So the wait times are causing huge problems for patients. I see the question. Do we know why people aren't taking up family residency aside from the fee-based practice? So a lot of it is because there's a lot of work that's involved, right? Like sometimes the doctors don't feel comfortable being businesses. So that's oftentimes why you'll see kind of like big amalgamations of clinics. Rarely do you ever see a clinic where there's one sole doctor. Oftentimes you see clinics that have multiple doctors. So that makes things complicated. And also, there's a post by Doctors Manitoba recently, actually I think it was in the news, where there's just so much excess paperwork that doesn't need to be filled out, but they just have to fill it out for bureaucratic reasons. Doctors Manitoba is working on reducing that paperwork burden, but that's, there's so many factors that contribute and make the business model of primary care so complicated that it's almost scaring off doctors from pursuing family medicine. Also, there's like that notion that like family medicine isn't like as sexy as like other practices like cardiology or like oncology. So I think there's like the kind of the lame stereotype associated with primary care, and just like the administrative barriers that they have to deal with. But still, like I know so many family doctors who say like it's like the best job ever. And I even want to work in primary care. So yeah, there's just kind of a couple, it's mostly bureaucratic things, and it's mostly stemming from the fee-for-service model, which causes a lot of problems, for attracting doctors to the family medicine practice. But it's complicated, it's a very complicated issue. Great question though. Rip, yeah, of course. So, okay, good question. So does the business model or fee-based practice apply to other specialties other than family med, such as cardiology surgery? So my understanding is that when you work in a hospital, you are paid by the hospital. So all the administrative fees are covered by the hospital. The hospital does the admin department stuff billing for you. And so technically you'd still be considered fee for service, but the hospital is there to kind of manage you. And the hospital kind of covers all your fees and stuff. But if you work outside, like if you work at a private surgery clinic, like There's one over on Lorimer, Western Surgery, I think it's called. I would assume that they do fee for service billing, because they are not like within, like they're their own business, whereas the hospital is kind of the hospital is itself a business, but because the hospital is so large, they have admin people to take care of all that stuff for you. So yes, it's all very complicated. The Health Canada Act is honestly such a complicated topic. So of course, there's also growing lack of physical access to care due to geographical barriers. For example, if you live in the east end of the city and your doctor closes practice over there and moves to the west end of the city, you have a hard time accessing that care if you don't have a car, or like there's no good bus route there, right? And finally, there's also, of course, as we know, unfortunately, institutional prejudices that still exist. I have a really sad story that again, the same friend of mine who's a transgender male, transgender man, he was unfortunately assaulted, and he went to the HSC emergency room. This was in December 2022, and he was consistently dead named to the point where it had to be intentional. There is no other reason why my friend, who's a man, should be dead named consistently. Like, and poor thing, he had to keep reminding the staff there, like, no, he, him. And they just like refuse to do it for some reason. I don't know. But so like institutional prejudices still exist in the system, and this is causing barriers to primary care. Of course, there's other issues like cultural factors where doctors don't feel comfortable or confident in providing culturally competent care. Also, the cost of living are increasing, as we all know. Also, generally, sometimes poor health literacy, and understanding your health is the best way to improve it. And finally, I'm sure we all know as well, allied health services like dental, OT, PT, MT, and other rehab services, mental health services, and other complementary health services are all paid, like we have to pay for them out of pocket. And that just makes everything so much harder when it comes to primary care. And it's even worse outside the city. You know, I talked about the doctors in rural Manitoba and how if there's a community of 200 people, like a doctor will very seldom keep their clinic there because they just can't make ends meet. No matter how much of a good heart they have, they can't make ends meet if they only have 200 patients, and a typical family doctor practice takes on about 1,000 patients. So you can't make ends meet, and this just makes everything worse for all of this. Yeah. Okay. And then of course we can't talk about primary healthcare without addressing more systematic inequities faced by Indigenous peoples. There's two stories that I was going to talk about, but we're just kind of already halfway through this talk. I want to make sure we get to everything. So I'd encourage you to look up Jordan River Anderson and Brian Sinclair. So I'll just give you the brief. Jordan Anderson was born in 1999 and was from Norway House Cree Nation. He was born with a rare disorder known as Cary-Feynman-Zeider syndrome, and that kept him in the hospital from his birth. And when he was 2 years old, his medical team said he could move to a special home to take care of his medical needs, while allowing him and his family to have like somewhat of a normal life, being at home, not at a hospital. However, the federal government and provincial governments could not agree on who should pay for the services for 3 years, and Jordan died in hospital. Awful. And then, of course, Brian Sinclair, he was in the waiting room at HSC for 34 hours waiting for care, and then he eventually died there because he had a blocked catheter. And people thought that he was fulfilling some racial stereotypes that I'm not going to say because I don't want to perpetuate them. But there were stereotypes in play that made the practitioners there think that, oh, this person is not here for the right reasons. And he died in the waiting room waiting for care when the issue that he had, this blocked catheter, was so preventable and so treatable. There's also a book on him called Structures of Indifference, an Indigenous Life and Death in a Canadian City by Mary Jane Logan McCallum and Adele Perry. It's a quick book. I think it's like 200 pages. Highly recommend. It talks about the history of course, Brian and Winnipeg and the HSC itself. So if you're interested more about that, read that book. That's a great book. Okay, and then again, bring this all back to Manitoba and tying this into chronic diseases. I want to bring your attention to some of the key stats that highlight the increasing urgent conditions here in Manitoba. So approximately one in three Manitobans are dealing with chronic disease as of 2010. That has since increased, according to Canada-wide digits, to 41%. I see a question. Yes, I can put the name of the book in chat. Absolutely. Thank you for asking that. I will also send out the slides too as well. And Camilla will as well. Anyways, so that's the number of Manitobans dealing with chronic diseases. And then also as of 2019, our population of 65 plus adults is expected to increase by 31% until 2028. We're about halfway there. And of course, we're still increasing in our proportion of older adults. And finally, Manitoba has the second lowest rate of general practitioners in the country per capita. For context, the Canadian average is 124 GPs per capita, with the capita scale being 100,000 people. And to make things even worse, we are only 1 to 3 doctors better than Saskatchewan in terms of per capita care. So we're second worst, but not by much. We might as well be worse than in the country. Not great. So again, how does this affect chronic diseases? Well, first of all, chronic disease can prevent, primary care can prevent a lot of the factors that cause chronic disease, or help take measures to reduce the risks. So first of all, like we have individual factors like sex and genes. Those really can't be changed. Sex, of course, can be changed, but genes really can't be changed. And so primary care can provide people with the tools to become aware of their risks, right? So being aware of your risks will encourage you to seek more preventative care. So like people who have the BRCA gene mutation, they go get screening earlier for breast cancer because they're aware of this gene mutation that they have. And primary care often initiates that. Of course, lifestyle as well. We know that use of tobacco and alcohol and physical activity increases your risk of chronic diseases. So when primary care suggests that you don't smoke, it's for your that as a preventative action to prevent you from developing a disease like chronic obstructive pulmonary disease or COPD. And of course, environment, primary healthcare can't directly change environmental factors, but they can provide you with resources to address problematic environmental conditions. So if you're in an area where you can't access, or if you're in a situation where you can't access like private counseling services, then they can provide you with tools to access like WRHA counseling services, or other like a sliding scale type of counseling service, while also providing information on like food banks and stuff. So the primary care model is designed to kind of reduce the risk of chronic disease development. But there is one factor that really contributes to chronic disease diagnosis that is kind of on here, but not really, and that I've touched on. Any guesses what that is? That really can't be controlled by any doctor, no matter how hard they try. Age is a huge problem when it comes to chronic disease diagnosis. No matter how good you are at addressing these factors, age will still cause some proportion of the population to develop a chronic disease. So even though we can do all these things, we're not totally exempt from chronic disease burden, which is why primary care is so important, because they are the primary managers of chronic disease. Okay, cool. This is going to be a pretty long slide, so I'm going to zip through it, I think. So just generally, chronic disease patients report having generally not the best care, with only 66% of Canadians self-reporting receiving adequate care, and issues that affect patient satisfaction include long wait times, inappropriate treatment options, and a lack of physician understanding and support. And with more physicians retiring, and this will only get worse. Also, patients with chronic disease require more primary healthcare visits than those without chronic diseases. And so, as we see here, as 2014, while approximately 41% of Canadians suffer from chronic diseases, they account for 62% of primary care visits. So for example, I know someone who has depression, and they go to visit their doctor 2 to 3 times a year. Oh, sorry, once every 2 to 3 months. I apologize. Versus like the average person who might go see their doctor 2 times a year, once for their annual physical and once for another reason. So they just see the doctor way more. And also chronic disease management is becoming more complicated. 17% of Canadians have more than one chronic disease diagnosis, and 6% of Canadians have 3 or more chronic disease diagnoses. So these patients are becoming increasingly complicated, which is making taking care of them more complicated. So clearly, I think I've laid it out to you that we're facing a bit of a problem. But there are solutions, right? That's kind of why people do research. That's why I'm doing the research that I'm doing. There's solutions. So first of all, there's called a team-based approach, and it focuses on like task shifting. And that's exactly what it sounds like, where different team members take on different roles to best serve a patient's need. For example, the most complex patients, perhaps the chronic disease patients, are seen by the physician, and moderately complex to less complex patients are seen by physician assistants, nurse practitioners, or public health nurses, or mental health concerns are seen by a counselor, or drug questions are seen by a pharmacist, or home care and other rehab needs are seen by like a rehab supplier, like a OT, PT, or they're seen by a social worker. So having this task shifting and team approach to care allows for all team members to best contribute and be as productive as possible, thus allowing each patient to access the best kind of care needed, right? So if you have 100 patients who all have different levels of care needs, but they only have one doctor to see, that doctor's schedule becomes very full. However, if you have a bunch of other different kind of levels of care, the patients who maybe need like low acuity care, for example, maybe they have an ear infection, they can go see a nurse practitioner or a PA to address that need, leaving space for that chronic disease patient to go see their physician to address their complicated needs. And this also is beneficial because chronic disease patients, like I mentioned, need more contact time with their doctor. So just having more routes for patients to still be seen just allows for better care for everyone. But there are some concerns around this. So there's concerns about confidentiality, and some patients don't necessarily want a team of 10 to know their entire health data. So research is needed. So this is why we're here. There's also ubiquitous healthcare, or U-Healthcare, or eHealth, or mHealth, a bunch of different names. So I have a question: when they have to see their doctor anyways, if there's a prescription concern. So in the case of nurse practitioners or PAs or physician assistants, they can prescribe most drugs except for narcotics. So they'd be able to see a PA for that kind of thing. And also pharmacists are starting to become more able to provide scripts anyways too. So like currently pharmacists can prescribe scripts for, I think it's UTIs, smoking cessation, and there's one other thing, I guess they can provide vaccines. So just having more ability for having more ability for different practitioners to provide like, for example, prescriptions, makes it a little bit easier for everyone to kind of get the best kind of care. And examples of course, no problem. And examples of narcotics are typically like opioid-based pain medication. So I'm pretty sure T3s fall under the category of narcotics. Don't quote me on that, but that's like the kind of drug that would fall underneath the narcotic category. Yeah, there you go. Okay, and then of course there's ubiquitous healthcare. So that's just kind of like the idea that you are kind of always in contact with your healthcare provider. So in this case, this patient's diabetic, and they're taking a blood sample and they're sending it to their medical team, and medical team is sending back information to their patient based on what the patient needs. Chronic disease patients kind of need a lot more, like I said, monitoring. And so this may be beneficial because if a chronic disease patient is supposed to see their doctor once every 2 or 3 months, maybe this constant monitoring will help reduce the number of times that patient needs to actually go in and see their doctor, because they're always being monitored by the doctor based on blood work. They won't have to go in as many times to see the doctor to talk about their health. Kind of complicated. So it's allowing doctors to better monitor patients' health, but there's of course limitations. One, this is very expensive, and two, there's also just kind of a little bit of distrust from patient and provider due to like the lack of experience, although it is getting better because of COVID and all those kinds of things. But again, this needs to be researched more. And because of COVID, again, there's been more research on it. So there's 2 articles here talking about different types of healthcare that are being employed. This one on Nuna is actually really interesting to me because it's for cancer patients, and they've actually just started rolling out this this service to patients at Cancer Care. So I'm guessing that they're doing research on it there, but yeah, super cool and innovative stuff. And there's also a bunch of new technologies. So there's better data collection tools, like it's easier to access data, especially when we think about this ubiquitous healthcare service. It's easier to access data, especially Manitoba. Like we have this amazing system here in Manitoba called the Manitoba Center for Health Policy. It's this huge data repository. Everyone who's in this call is definitely, not just definitely, is probably in the system. And it makes data access for research so much better. There's also new drug modalities. So like for patients who have atrial fibrillation, they take this type of drug that's normally taken through IV, but they're trying to find a new way, and they have found a new way to get drug to better allow for the drug to hit the body through what's it called? Through like inhaling it. So it allows the drug to hit faster, and it's also way more easy to like take it at home or at work or stuff. Okay, I see your question. Yeah, so the question in the chat is, yeah, so again, so this person is talking about the barrier of continuity of care. And yeah, patients who aren't keeping up with their bookings, and then of course, pharmacists can't always fill all the medications that a patient might need. So for example, this patient is talking about blood pressure and cholesterol meds, which a pharmacist can't prescribe. Yeah, my partner's mom is a pharmacist, and she's trying to push for pharmacists to be able to prescribe more things to deal with situations like that, but we're not there yet. But that would absolutely help with this whole thing. Yeah. Multi-omics and algorithmic models, also very cool. Multi-omics data looks at like your genes and kind of looks at the genetic aspect of why you might have a disease. And algorithmic models are also really cool. That's what I'm doing. That's what I'm doing my research on. If you want to hear more about it, you can ask me in an email, or I'll send out my information to you guys about that. But we only have 10 minutes left, and I want to get through some more slides. So we're gonna move on from that. So the current model of chronic disease management, like I said, is reactive care and not preventative care, but using principles of like epidemiology and public health. A way of tackling chronic care could also be chronic disease management would be thinking about upstream thinking. This is central to public health and epidemiology. In fact, one of my professors at the university shared that this concept is so central to public health studies that for his Master's of Public Health commencement ceremony at UCLA, the program provided their graduates with salmon-colored stoles to represent and highlight the idea of swimming upstream. It is so the sorry, like how salmon do. So it is so like the basis of public health and epidemiology. So that's another way of thinking about it as well. And to talk about that more, I want to say that this is rooted in Indigenous knowledge. And I wanted to highlight, I chose one particular article to highlight this. It's linked down here if you want to read it. And it was actually done in Manitoba, and it talks about how the Indigenous perspectives for how we can improve primary care here in Manitoba, especially for Indigenous and rural communities. So their ideas are consistent access, so a better continuity of care and timelier access, equity in equipment and personnel and resources, healthcare that is closer to home, in the home, with more accessible transportation that is community focused and not individual focused, care that is culturally relevant, allowing for Indigenous ways of knowing and medical practices to be intertwined, more affordable, healthy food. We all have heard about how expensive food is up north. And then cooperation between the provincial and Canadian governments to help with payments and who's providing what services, which we kind of touched on in Jordan's principle. And if you notice, a lot of these themes are addressing barriers that I mentioned in one of the previous slides. Yeah, I think Indigenous knowledge is so central to will help us in so many ways to fix our primary healthcare system. But the problem is that even though we can think that governments have to invite people to the indigenous people to talks that matter, right? So there's recently been talk about new health spending by the federal government, where all the premiers were invited, but not a single indigenous person was invited to the table. No individual, no organization, no one was invited to the table. And that's already compounded by the fact that indigenous people already don't have the services that most white people do. And so it just kind of really screams that they're not being taken seriously when they need to be taken seriously, because they have, one, amazing ideas, and two, they experience often the worst health outcomes because of the way that the healthcare system discriminates against them. So yeah. If you want more readings, Better Now is a great book about 6 big ideas to improve healthcare for all Canadians, written by a doctor in Toronto, or somewhere in Ontario. I think it's Toronto, but somewhere in Ontario for sure. Great book. Also another book recommendation, The Scalpel and the Silver Bear. This is a book about incorporating Indigenous knowledge into medical practice. Not exactly on the topic of primary care, as it's talking about surgery, but just another fabulous book. Highly recommend it. I will also put the Brian Sinclair book in the chat as well, another great book. And finally, I just want to do a couple quick shout outs. So thank you, Camilla and the MHRA team. I want to thank Dr. Navdeep Tangri and the CIC team for our guidance and providing me the opportunity to research chronic diseases. I want to thank Dr. José Lavoie for her expertise on Indigenous health and primary health care in Canada. I want to thank Elder Grandma Shingus for sharing her endless wisdom. I want to thank Miosha Sode for constructive criticism on my presentation. I want to thank Dr. Jeffrey Marcus and Dr. Melanie Lalonde for sparking my passion for research. I want to thank my family and friends for their constant encouragement. And I want to thank you all for being here and wanting to learn from me and wanting to pursue research. You are all the future. And I'm very happy that you're here and coming to learn and wanting to pursue health research. You are going to make the difference in the world that we need to see. And yeah, awesome. Thank you for being here. Thank you all for being here. I know we're 8:01, so if you gotta take off, that's totally fine. I will hang around for a few more minutes though, and field some questions or have some discussions. Yeah, thank you everyone. I hope I've sparked your primary care passion.